Good morning, everyone. My presentation today will be about ERCP standard cannulation. We always aim for successful cannulation, but this should be in the most efficient and safe way to minimize complications, especially post-ERCP pancreatitis. We should always keep in mind there is no one technique fits all situations. There are numerous factors that affect the cannulation rate, which include the morphology of the papilla, altered anatomy, ERCP indication, techniques, and accessories used. It's imperative to get acquainted with different accessories and techniques for successful cannulation. For successful cannulation, we have to get the papilla in a good position. This is by positioning of the patient, usually in the prone position, and with good shortening of the scope, which gives an optimal view and stability of the scope. Before cannulation of the papilla, you should have an access plan. Take your time, study the conformation of the papilla, choose your technique, and choose your instruments. With the papilla in face, the direction of the common bile duct will be around 11 to 1 o'clock, that means upwards and to the left, and the pancreatic duct at 3 to 5 o'clock. For cannulation, we have different techniques and instruments. We have the standard cannula, which comes with various types according to its tip. We have the conical tip, the bottle-shaped tip, the fusiform tip, and the most commonly used one is the rounded tip. Cannulas come with two ports, one for contrast injection and the other for the guide wire. We have different types of sphincterotomes. They come in short nose, the most commonly type used, the long nose, and no nose at all. We also have a reverse cut, which is useful for patients with altered anatomy due to previous gastric bypass surgery, such as Roux-en-Y or Billerith 2. Guide wires come with hydrophilic tip, which might be straight or angled or G-shaped. The most commonly used one has a size of 0.035, but a thinner one, 0.025, is available. For standard cannulation, the sphincterotome is preferred over a standard cannula, with nearly 20% more success rate. There are two ways to achieve deep biliary cannulation, either guide wire assisted or contrast guided. We can see here that the sphincterotome has the advantage of bending, which gets the guide wire in the axis of the CPD. Guide wire assisted cannulation is generally preferred over the contrast guided technique to decrease the pancreatitis rate. Wire-guided cannulation can be performed in two ways, sphincterotome first or guide wire first. For the sphincterotome first, after engaging into the papillary orifice, the sphincterotome is gradually bent toward the expected bile duct axis, with gentle manipulation of the guide wire using a combination of torque and push. For the guide wire first, the guide wire protrudes 2 to 3 millimeters outside the sphincterotome, enters the papillary orifice first, and is manipulated into the duct of choice. The technique is especially useful for cannulating small or stenotic papilla. In either method, the guide wire manipulation should be gentle to avoid mechanical trauma to the papilla and creation of false passage. If the guide wire enters the pancreatic duct, it's withdrawn and cannulation be attempted after flexing or relaxing the sphincterotome to a different degree. In difficult cases, approaching the papilla from below, shortening the scope, and relaxing the elevator, followed by pushing the scope down, as the assistant maneuvers the guide wire into the bile duct might help. Repeated entry of the guide wire into the pancreatic duct should lead the endoscopist to adopt alternative techniques such as pre-cut sphincterotomy. Contrast-guided cannulation has largely been given up because of increased risk of pancreatitis. A small volume of contrast might provide guidance regarding the ductal anatomy and can guide a wandering guide wire. The volume of contrast injection shouldn't be more than few millimeters, 2 to 3 millimeters, to avoid filling of the pancreatic duct beyond the head region. And we have a hybrid technique, which means blending both techniques. A small volume of contrast is injected to attain a roadmap of the terminal CPD, followed by guide wire push in the same direction.